Hi, I'm Michael Courtney. In this video, Rosalba Courtney is looking at the challenges of assessing and treating people to help them normalise their CO2 levels. This is taken from her professional training course, looking at addressing hyperventilation, and this is taken from her hour-long recorded lecture on that topic. Enjoy.
So there are challenges in normalising CO2. Individuals' resting CO2 set point is notoriously difficult to change. You can't show a person a breathing exercise and the next day their CO2 level has changed. It takes 4 to 6 weeks training, and as you saw from the Murray studies, 12 months people can still be improving. And CO2 homeostasis is complex, and once it's disrupted, it can be hard to get right again because you've got to restore bicarbonate reserve and mineral balance in the cell and that sort of thing. And that just takes time as the body's restoring its CO2 homeostasis. But also, the feeling of CO2 is uncomfortable. And in some people, the feeling of CO2 raising can make them feel anxious, and they can really have a very poor tolerance to dyspnea. So that's one of the factors. Another challenge is that people will tend to try and maintain the CO2 level that they're familiar with. And when you begin to teach them breathing exercise, they will compensate. So if you do low tidal volume breathing, like reduced volume breathing, they will compensate by increasing their respiratory rate to maintain the CO2 to what they're used to. And if you give them slow breathing, where they're reducing their respiratory rate, they will sometimes compensate by just breathing more deeply so that they're still hyperventilating, but with a deeper breath. So control breathing by either reducing the rate or the volume of breathing doesn't guarantee that CO2 will increase. Another challenge that we have is just selecting patients. So I think it's really important to do capnometry to establish that hyperventilation exists and what the type of hyperventilation is. Is it chronic hyperventilation with a low resting CO2, or is it intermittent hyperventilation where it's primarily unstable breathing that you'll only pick up with challenge testing and the hyperventilation provocation test? And also, you really have to match the technique to the patient. So patients with a poor tolerance for dyspnea, where they get panic and anxiety very easily, the feelings of breathlessness, with a very poor tolerance to CO2, they can really struggle with breathing retraining. And then you might need to work with indirect techniques or using body focus rather than breath focus in the beginning. The other thing you need to be alert to is the presence of pathology and psychopathology, and to understand that some people may need to be referred. So there are a number of pathologies that will lead to hyperventilation, like ones that I've come across in my practice were people with cancer that hadn't been diagnosed, and also people with just really such severe trauma that they needed psychotherapy. And really severe PTSD, you often need to work with a skilled psychologist as well. Although sometimes it's just remarkable what a change you can make by working with these body-based therapies, breathing, relaxation, and mind-body approaches.